All right, welcome to the Hobo Thing of Podcast. My name is Crystal Cedino, and I am the Training and Development Manager for the Native Learning Center. I'm thrilled that all of you are tuning in for another episode this week. So thank you for being committed and just regular. We definitely appreciate you guys. With that, I have my right-hand lady, Cora.
Hi, everyone. I'm Cora Anthony. I'm the Training and Development Specialist here at the Native Learning Center.
Yes, and we have a few returning guests today, which we are excited about to continue the conversation of health equity within Indian country. And just, to get the ball rolling, let's go ahead and introduce them. So today we have Bart Garber, who's Director of Business Planning and Board of Director. Go ahead and wave to the camera, Bart. There he is. And then we also have Dawn M. Coley, VP of Healthcare Development and Tribal Relations. There she is. And then we also have Ashley Hesse, VP of Policy. There you go. And then lastly, but not least, Julie Garrity, Health Policy Analyst. Go ahead and say hi. There we go. Awesome. Well, thank you all so much for joining on another episode. And I know we have a few others planned, which Cora and I are very excited about as well. But today is, I feel like, a fairly really good one. Ashley was discussing earlier the meat and potatoes of it all. So with that, today we're going to be talking about state issues that relate to health equity and Indian country. So let's go ahead and dive in with our first question here. So what are some state level policies that are helpful in creating health equity in Indian country? Anyone want to jump in?
Well, I'll lead if y'all don't mind. And that's such a broad topic right there, health equity within Indian country and state level policies. And the other day we had a chance to talk a bit more about federal policy and how that, this provides the framework and guiding structure and some base level rules. Then we really get into the grayer areas. I find that this is where states then have to implement and carry out some of these policies and practices and interpret some of the guidance from the feds. And then, ideally incorporate and involve all stakeholders to the table when reforms and initiatives are undertaken. Unfortunately, all too often we find that Indian tribes are not really at the table when it comes to dealing with states. And states, being the political machines that they are, our state governments, and how hyper politicized everything has become, it seems to be at times a little more difficult to make some headway on some policy reforms that could bring about greater health equity within Indian country and other regions. But I think right now there's a great opportunity for this current administration to move things down to the state level to really try to work on rooting out some of our systemic racism and practices that have all too often marginalized people of color. And I think really that starts to get to the root of a lot of our challenges. So when we start talking about health equity and improved health outcomes, a lot of it, when you get right down to the brass tacks, it seems a lot of it comes down to payment reform and delivery system reforms on how these health systems are, again, implemented, the levels of accountability, their focus on things beyond maybe, healthcare proper, but into some of our social determinants of health and the things that have really started to stratify our access and the types of quality of services or the types of services people that can get they can receive in their state Medicaid plans. And I find that the payment reforms are a very big part of the activities that states can engage in, and there's been a long-standing movement on saving money, through our state Medicaid, because it's a shared program, between the federal and state government, and each is contributing a certain percent of the cost, to pay for our Medicaid programs. And I focus a lot on Medicaid because there are so many American Indians, Alaska Natives that are Medicaid eligible. When we talk about health equity and the people that seem not to have access or quality of care, and it tends to be folks that are in the lower income spectrum. Or people that are marginalized for various regions, geography, and other things. So to me, I just say like payment reforms, I think are a really big area. And what we've been seeing, and Dawn and others can speak to this too, for several decades now, a push towards a managed care model. State healthcare agencies, departments of health, however they're organized, they've been, in my opinion, starting to offload their responsibility and their obligations as state agencies to oversee and direct and manage the healthcare of people for decades now, putting that out into third-party entities, non-governmental entities, and then saying, here's this third wheel now that you have to deal with, and so that whole payment reform and systems push to a managed care model, whether it's primary care, dental, behavioral health, and all that, that seems to be where the most of the levers exist for states to increase health equity. And I'll stop there. We can talk more about it as well. But others, I think, on the team maybe can speak to some of that too.
Yeah, just going off of what Ashley was talking about in the beginning, the political issues around states sort of implementing these policies to help with health equity issues. A lot of what we're seeing in our research is when we look to who we would reach out to, how we would get this started, there's X, Y, or Z policy we would like to see implemented. Okay, well, let's look into what the state legislature looks like. How do they call roundtables? Is there a standing committee? A lot of these political machines at the state level don't give a seat at the table for tribal leadership or for any kind of correspondence. There are some states that do it, well enough where you can, like in New York, for example, there's a committee that can be called to a roundtable to discuss state and Native American relations. But other states, far too many states, don't have any standing committee, no interim committee, no opportunity for anybody to really come in and say, hey, this is what we're missing, this is what we need. So that level of advocacy that could really help push health equity initiatives over the ledge and really make them possible. What we're looking at now is how could we get these things sort of set up? Who could we bring this up to? Who in state government could help make it happen? So I think that's the political landscape is a really important aspect of a lot of these problems going on now.
We wouldn't really be talking about state problems and Native or tribal healthcare delivery if there weren't 3 different jurisdictions and 3 different governments fighting over responsibility, or even if they're not fighting over responsibility, having their own organizations that are driving initiatives in their own lanes. It's as if we've got 3 different game boards at a table, and they're not all 3 chessboards. One of them is chess, one of them is checkers, and one of them is a different game altogether. And we're trying to coordinate the rules that are different and sometimes the objectives that are different. It's worse than a Star Trek 3-level chess game, because you have the federal government who originally took on the responsibility of providing healthcare to natives. And then along the way, they got kind of, nudged to let the tribes start taking that over. So about half of the IHS budget now is managed by tribes. At the same time, the Fed, as it walks out of healthcare, it retains it at a public, healthcare level and health and human services and all of the various policies and initiatives that come out of there from, dozens of different agencies that fall down into the population. At the bottom side, tribal members are members of tribes, and those tribes are serving them, or those tribal members are going to an IHS facility. But what you sometimes forget is that all tribal members are citizens of a state. So they benefit from the policies and initiatives of a state. But yesterday we spoke about tribal FQHC, where the Health and Human Services, CMS, attempted to try to drive a policy down through this pile, kind of like trying to drive a nail down through, 4 layers of wood, to come up with a way to unitize and simplify enhanced billing for tribes in the Medicaid, Medicare area. But when you go to the other end of it, state of Alaska, for one example, was responsive and receptive to it. But when you get this rule book that comes from CMS on tribal FQHC, the state of Alaska has a different rule book. turns out that if a tribe takes up a tribal FQHC, none of the things come together. They literally put a joint committee in a fairly friendly environment together with some high-level advisors, attorneys, native healthcare attorneys, and native healthcare administrators. And they've taken a year to try to straighten those rules out between the two so that tribal FQHC could work in Alaska. And that's a situation where everybody's kind of agreeable. Imagine when they're not. So that's what you really are looking at here. If it was just healthcare, it'd be one thing. But you got healthcare and then these vectors that are coming in about what are the solutions for it. And not just that, but you got bureaucrats there say, hey, it's my job. And so they have a whole set of regulations. And like I said, there are at least 3 different games going on with at least 3 different rule books. The Fed claims that it has, if all other things fail, federal law prevails. But law and healthcare policy sometimes don't make any difference to one another. Okay, great, you're better than I am. We still got a sick person here. How do we take care of them? And who pays for them? So this is where Ashley and Julie can really talk to you about the ground game. But what I wanted to explain was this larger environment and why you're dealing with this. It's not like people don't want to solve healthcare problems. They just want to do it in their context, in their little cubby hole with their own little rule book. And they're all playing from different rule books to some extent.
Yeah. Bart, I love your analogies because I feel I'm such a visual person. So like the fact, with the nail going through the 4 layers of wood and then the game board, I think it helps. I mean, it helps me, and I think it would help our listeners to, understand that kind of, that's why things really aren't working the way that I feel like they should be, for people, for tribes, and so on and so forth. So thank you for those analogies. They're helpful for me. Definitely.
So I'd just like to add, this is Dawn. I'd just like to add that, so Indigenous Pact, will be contacted by these community health centers or health directors, program directors. And, they'll talk about these experiences. I'm not getting anywhere with the federal legislative, process. CMS isn't conducting, tribal state consultation. And we really need some guidance and we need help. And we know that you have that experience or expertise to help us with this. And so I just want to add that, we have Bart, Ashley, Julie, and our whole executive team, and this is what we focus on. We focus on navigating, again, these tribes and our partners, through all of this. Just would like to add that.
No, thank you for that, Dawn. I was actually going to mention that I'm listening to you guys speak, and I know that in Indian country and anything that involves so many rules and regulations and whatnot, there's always that disconnect, and we're missing the point that we're here to help the communities. And so sometimes these entities just cannot get so wrapped up in the red tape and all the procedures and whatnot, and we're missing the people. Like, this is what we're here for, and we're so focused on all of the nonsense that has nothing to do, instead of focusing on how do we work with each other to have the federal build on the state programs to help Native American communities and whatnot. So like I said in the other recording, it's exciting for me to know that there's organizations out there that are trying to fix those miscommunications and kind of bring the whole picture together and say, hey, focus back on the people. It's the people that matter, not everything else. So while we speak on the work of states and whatnot, can you guys share a bit about tribal federally qualified health centers and some of the states that have them?
No, absolutely. And this is like, Bart was just mentioning, this is sort of like where those nuances come in, and Julie can certainly help speak to this because I've had her help me do a deep dive, and it took us a significant amount of time and effort to do a national scan of what are the states that have enacted rules to allow for tribal FQHCs and tribal health centers to be designated with that specific title, if you will. And, you know, it was interesting, just a bit more about that. You know, you really had to go to the state the Medicaid website, and you go through each and every state plan amendment, and these are state plans and or waivers, you know, demonstration waivers that kind of waive Medicaid rules. So you have to go through state by state and look for keywords and list and dig through all of the hundreds and hundreds or however many out there, state plan amendments and demonstration waivers to try to find out, okay, what states are moving in this direction and what does it look like? So right now, I believe we've come down and we finally had it verified by CMS, and that took a significant amount of effort to get them to verify this, but I believe we are about at 12, I forget what's my numbers here.
There's 14, Ashley.
14, yeah, I'm just looking at my list. Yeah, currently 14 states, we believe, have some form or another of a tribal FQHC designations, alternative payment methods that come with that.
Yeah.
Go ahead, Julie.
So I was just gonna say, you can go ahead and finish. I'll go after you.
Oh, I was just going to say, so, but the variations amongst how it's carried out and who qualifies and what type of alternative payment method and what limitations exist, it varies greatly from state to state. You have some states like Washington, for example, they allow for 5 outpatient visits per Medicaid beneficiary per calendar day for professional services. And this is like, these are paid encounters. I could go in and see a podiatrist. I could go in and see a dentist. I might see an ophthalmologist. I might see a, counselor, and I might have to go in for something else. I mean, that would be like 5 different encounters. The FQHC, the tribal FQHC could then, claim for reimbursements and bills. But other states might only limit it to 3 encounters per day or 2 encounters per day. They might only limit it to certain types of services, Medicaid eligible services. So there's a lot that goes into it, but I'll stop there. And because Julie has done a lot of work, and Bart, you have something to say too,
Yeah,
please.
Laura, before they put the diving suit on you and go down a few thousand meters, let's understand why tribal FQHC is the issue first. States have federal qualified healthcare clinics, and then they have those that aren't. And they are able to bill differently, even where you don't have tribes. There are certain entities that form that get into that rule book for different reasons in a state. As it turns out, at the end of the Obama administration, the Health and Human Services group, I was running a small tribal healthcare organization in Alaska with 1,600 tribal members and 300 plus employees. And we had positioned behavioral healthcare clinicians or technicians out in schools right beside Native students to help them, those that had disability or learning issues. And so they were in a school outside of the clinic. Suddenly there's a missive that comes out of Washington, D.C., thrown at you like a very dangerous paper airplane that said, we will not bill for your services if you don't bring that client inside your IHS certified facility. So they said, you have 4 walls. You can only provide that behavioral health service within those 4 walls. And we said, huh? We've been doing this a long time. And so when everybody complained, CMS then passed an emergency regulation or emergency administrative order that said, okay, we will put this thing off from enforcing this for a while. And we're going to tell you that the way to solve this is that most FQHCs in states allow Medicaid to pay for services outside of a clinic. So if you get a tribal federally qualified clinic, FQHC, then you will be able to bill for those services you do outside the 4 walls, but you have to qualify as a FQHC in a state. So that's now why we call this a tribal FQHC, so that we can do services outside and bill for those services. And so it's particularly important for us with opioids because most IHS facilities, they will do some opioid treatment within the walls, but most opioid treatment is outside in a special clinic. And a lot of times you have to go out to where addicts live, and they typically don't live all around the clinic. So, it's been kind of important for us to find states that have tribal FQHCs to be able to operate an opioid clinic effectively. But it's not just opioids, it's other behavioral health services and other services that you might provide outside the four walls. So what the tribes found out and what CMS has been informed of is that that FQHC doesn't mean the same thing in every state. States have the ability to put a little menu together for what it will pay for and what conditions, and that's what Ashley was talking about. So when you go out and, you know, CMS says, oh, well, you can just become a FQHC. 14 states, at least 14 different ways to collect bills or to submit them and procedures, because they all have different rule books. Illinois doesn't like to do it the same way that Washington does. It doesn't like to do it the way Wisconsin does, or it doesn't like, but they simply don't. And so that's where the chess game, or the chess and the checkers game, get all confused.
Yeah, I think a really important part that Bart hit on to understand about FQHCs and tribal FQHCs is that FQHCs were created to be safety net providers. So they're supposed to help enhance health outcomes, help access to primary healthcare services for communities that don't have access to these things, for communities that are already struggling as is. So something like a four walls requirement, which just further restricts and suffocates the whole point of an FQHC, does nothing to help anybody. It keeps the FQHC from meeting its ends. So for example, if there's an FQHC on a reservation in, you know, whatever state in a rural area, if they do succeed and they decide to expand, you know, they want to add, they found a room they can rent out where they can add a dental chair. You know, they don't have a dental practice now, but we can add a dental chair and we can refer our patients over there if they're having some kind of oral issue. Because it's outside of the four walls, all of a sudden the Medicaid benefits don't apply. You can't get reimbursed for it. There's no point in, you know, trying to add these services, trying to add another social safety net for these communities if, you know, you can't afford it and it's going to end up negatively impacting the entire clinic. So the four walls requirement has really been a wrench for a lot of the FQHC goals and initiatives. So that is where the when you can get designated as a TFQHC and get around the four walls requirement, it really makes all the difference. It gives people better access to the healthcare that they need. It gives clinics the opportunity to flourish and expand. So I do think that that is a really essential part of understanding why FQHC is being turned into tribal FQHCs is so important, and it's why it's so much of what we focus on now.
And this is why I love my team, because I will, like Bart said, I'll start at the bottom of the ocean and go around and think, oh, you don't know where I'm at or what's going on. So yes, thanks for clarifying some of this and contextualizing it. It's just my brain.
Ashley, let me set you up for this next one, and that is tribal FQHC is simply one specific example of how healthcare operations get complicated with the various jurisdictions. But it starts at the very beginning, and that is tribes under the 638 Tribal Self-Determination Education Act are able to contract to provide BIA and IHS services. So all the, well, in most cases, I would imagine there must be one or two tribes that actually have a healthcare facility that has nothing to do with IHS, but that they licensed on their own, because just like anybody else, they could get doctors, they go through state process and create a clinic. But in most cases, the easier way to go about it is to assume the operations of a federal clinic and take on their licensing, take on their personnel, take on their facilities, and take it over. But they do expand, they create new clinics. And the federal government, other than in a few cases like CMS that certifies drug treatment facilities under a SAMHSA list and other things, most of the time, this is where the Fed passes off to the state and says, okay, state, I have just nominated this tribe and authorized this tribe to take on our role. The tribe wants to expand. It has to go to the state for licensing and certifications. And this, Ashley, why don't you talk about that relationship and some of the difficulties you get into from state to state when you have to actually get set up for operations through licensing and certification?
Yeah, and that really that is a big part of it, because then it starts, you have to parse that out by service type. By service type, is this elder care, in-home care services, and then, the tribes, we've got an elders program. We're federally funded, but then you try to get into a Medicaid reimbursable service, and there's a whole slew of credentialing requirements and state, mandated processes where in reality, states need to kind of recognize that the federal government is using the Medicaid program as a vehicle for the federal government to meet its trust and treaty and obligations to provide for the health care of Indigenous peoples. They're pushing more and more third-party reimbursements, saying tribes and tribal programs and Indian healthcare programs, you have to get more and more third-party reimbursements and revenues in, run your operations like a business, because basically I've been to more meetings than I can count with different CMS representatives, regional reps and others at different conferences, and that's the message. Run your ship like a business. You need to make money because there's really no more money coming in from HHS. I mean, we can fight, we're moving. We've made some inroads in this last, our pandemic, but we're still grossly underfunded, and then as these payments and these systems are moving, tribes are then being forced to, get into the Medicaid provider game and go through the licensing, the credentialing, and all of that. And every state has so many regulatory barriers. Good reasons, they're concerned with quality outcomes, they're concerned with patient care. I don't want to disparage state Medicaid agencies in the sense that it may seem, but it's just there are so many bureaucratic barriers that interfere with this direct government to government relationship between the federal government and our tribal nations. And states are sort of these gatekeepers where their Medicaid programs and practices and bureaucratic policies for credentialing and licensing, and it just gets to be roadblocks that can be very difficult to overcome. Or the reporting requirements are more than the tribe would be used to, or it's totally different systems. So you're duplicating things. There's so much additional administrative burdens that can come when you try to get into that Medicaid provider game as a tribal clinic, that it can be intimidating, it can be counterproductive, and it can hinder progress and advancement and expansion of what we can do. So it touches on, I think, again, our home and community-based services are a big one, those disabled services, our elder care services, assisted living. I mean, you just run down the list of any state Medicaid eligible service, and if you track it back to which department, which agency, which, part of that Medicaid agency is overseeing it, there's all kinds of bureaucratic hangups that can get in the way. Much less we start talking about reimbursements and needing to educate the state. Like, look, if this is provided by or through Indian healthcare program to an American Indian or Alaska Native patient, 100% of that cost is federally paid for. So your Medicaid dollars from the state share, there's nothing that goes into the payment and the reimbursement for that person's care. So kind of get out of the way. That's my mindset. So in theory, is try to teach states how to kind of get out of the way and how to work well with the tribes. CMS, it's interesting. That's one federal agency that dictates that states have a tribal consultation policy, that states have to have a consultation policy when dealing with the Medicaid program and tribes. Now, if you look at what CMS has approved as consultation policies state by state, they're all over the place. Some are very robust and very thorough, and others are one line. Well, we'll send out a letter, we'll publicly notice whatever, and that's a pass. We consulted with the tribe. So go ahead, Bart.
I mean, you can imagine that you've got state bureaucrats who've been in a little cubbyhole and looking at a book and filling out forms for 20 years. And suddenly something drops out of the ceiling and says, you shall license, or you shall oversee payments of services to tribal healthcare facilities through a federal program. And they go, what? I'm a state employee. What are you talking about? And they will do the best they can. They're having to learn a whole new rule book. They're having to try to see how that rule book works out with their rule book. I mean, we have with some recent clients even talked to consultants that they have with long-term experience in, healthcare. And they literally ask us, well, will the tribe be treated as a government when we, submit billings? I mean, these are people who've been in the business for a long time. They don't even know that simple fact, much less the detailed regulations that they might have to follow. And it has consequences. One of the, well, not one of many specialties that Indigenous Pact has, and some of the ones that go back the furthest, is revenue recovery and billing expertise in this field, where you've got state rules, federal rules, and different types of billing processes and actual amounts, and have recovered millions of dollars. One, because the tribe didn't know to submit claims, and two, because the state didn't know how to pay them. Literally 10 years of underpayment by a state to a tribe that added up to multiple millions of dollars. In another case, another tribe had to sue to make that happen. Fortunately, they sued first, so we didn't have to pay too many lawyers, and instead paid billing specialists to take a look at the books and see what we could do to help that. Lots of tribes are so focused on expending their Indian healthcare core budget that they don't really pay that much attention to third-party payments or Medicaid billings or insurance, and have to spend most of their time just getting the regular work done, and not to see how they could actually enhance their services by increasing revenue. This is one of the ways in which we can, where Indigenous Pact really helps tribes, and we can focus on that, put processes in place so that they can repeat that into the future, and actually enhance their resources that they have available to provide medical services.
Absolutely. Well, I was going to ask too. Well, we're going to jump into the next question, but one thing that came to mind, and it kind of does play a role within our next question, is kind of like, how do we fix this? Where is the potential to grow health equity in Indian country? Because I mean, just between yesterday's conversation and today's, it's crazy to keep, it almost felt like a snowball effect, right? Where it's like, it was just one thing after the other that like you have to take into consideration, that's layered upon layered. So yeah, how can we kind of like, repair this, or, find, growth, within all of these aspects. So anyone.
Well, I think it's ongoing, as part of Indigenous Pact's mission, is to continuously provide that outreach and education, and be at that intersection to help the tribes to navigate through the regulatory, and all this policy that's impacting them within the state that they reside. So, I mean, it's ongoing, it's evolving. You'll see with all of these centers, that are a part of CMS, CCIO, the oversight, for the health insurance marketplace, all of these agencies, they're continuously having these conversations and looking for individuals to help them, move this. So Indigenous Pact is a part of that, and it's every day that we do our outreach and work with clients in each state, tribal nation, it's a continuous process and it's ongoing.
Yeah, most of these initiatives, even when they are in conflict, usually have very similar goals and good intentions. But it's kind of like, that little kids, educational game where you're given a circle, a triangle, and a square, and you try to put it in the right ones. Well, we've got a 3 or 4, and nobody ever gets it in the right one. Somebody's always trying to bang the triangle into a square, and then somebody else comes along with a circle and says, well, where does this go? Well, I don't know. And they're all there for good reasons, and I think one of Indigenous Pact's role is to try to consolidate those, to find continuity. When we go in and when Ashley goes in and talks to state regulators, they are experts at what they do. They know what they're doing. And so long as you can kind of use an advocacy role there to say, hey, this is what the Fed is trying to do. This is what the tribe wants. This is what you could do to make this better. Most of them go, all right, tell me how to do that. What little rules do I have to change? What processes do I have to go through? And so, we're not having to reinvent the wheel most of the time. We're just having to tell people what the wheel's for, and how to put it on the wheelbarrow a little bit better. No, not on the back, on the front. And then everybody gets to push it. So, and we're not even coming up with new laws or regulations. We're just trying to work with what's there right now. Ashley probably has other examples. I know he's the one that ends up having to talk to these guys most of the time.
Well, I don't want to take up too much airspace. It seems like Julie may have something to add too, but I think that point is really a good one that Dawn and Bart made, that there's a lot of education that goes on because everybody, I think it doesn't matter the profession in this day and age, everyone seems to be at their max, it's so like taxed, do more with less. And state agencies are absolutely no different. They're forced to continually try to corral increasing inflated costs within our health systems. You have this anti-government sentiment and small government initiatives and drives. And yeah, there's efficiencies, but you can only become so efficient. We have very large bureaucratic systems. Bureaucracies exist as a bureaucracy. They prolong themselves, so we've created these really large systems of care and ways of doing things, but then we get these newer modern ways and trends that says reduce the scope and the scale and who's doing what, so we're offloading it to third parties, and things get just really kind of messy. But I think a lot of it, like Bart noted, we're not coming up with anything really new. Do we have new innovative ideas we'd like to introduce? Do we have thoughts about new policies that we could try to really pivot or find some legislative champion to move through? Absolutely, we have ideas in that. But you really have to meet everybody where they're at, out of all due respect, and to be effective and efficient in what we're trying to achieve, which is to bring about greater health equity and opportunity and resources into Indian country. And for better or for worse, we have to work with these other partners, state Medicaid agencies are partners. And oftentimes, like Bart noted, it's not that everyone's trying to do anything, with ill intent. Everybody's trying to do their best work, but it can be so complicated and so challenging. And then to kind of, we think just make one little tweak here. Well, you've got committees and processes. You got, months and months and months and months and months just to change one thing in an electronic record system. Or we find a big part of it, and I'll stop after this, really is data. I mean, that's another, we come down to the identification of natives or non-natives in a state health system. Just going to their transformed Medicaid information system, just trying to understand what the states have to report to the feds on how Medicaid money was used and how, Medicare is carried out, and just the reporting system, you find big gaps. Like if you want to get to the granular levels, there's a lot of misidentification, racial categories. So then how is a state or a Medicaid agency or a MCO going to pay appropriately if we don't even track this person is native, this person is not native, this is where the claim came from, an Indian healthcare provider or non-Indian healthcare provider, or if it was through a contract with a non-native provider through the tribal system. Like it can do, depending on how the claim comes in, you can see it could get really messy and revenues lost and payments are missed. But we're just trying to find best practices in different states oftentimes and try to introduce it to other regions and try to fit it into what they're doing. And again, since there's so much state autonomy, it's not cookie cutter. There is no one size fits all approach. So we really have to be nuanced and tailored. And it's often, like Bart noted, just playing with existing rules and regulations and just trying to educate and share how it could fit better or how we could do things more appropriately. But yeah, the ultimate goal was to put the wheel on the front of the barrel, and so you can move a heavy load, and we're all trying to move this heavy load together. So we need to work together. But I'll stop there. Thank you.
Before we continue, I guess another part to my question is, are there states that are doing it well? And if so, can you name a few?
I would say Washington State. I mean, they're very progressive. And then Oregon also, that region, the Northwest, is amazing, you know, with some of the best practices that they've implemented. And I'll pause here for my colleagues that may have a different vision than I do, but I really do think that Washington State and Oregon are, you know, probably the most progressive.
You could also add, we haven't done that much work there, but I've spent quite a lot of time there. California also has a history of engaging tribes. They did it sort of way back before the Fed was even kind of pushing off contracting to tribes, because they were a Public Law 280 state where the Fed tried to pass off civil obligations and civil jurisdiction to the state. And one of the first things that the state did was take on healthcare. And so they have literally a statewide rural health organization that represents and serves or helps to advocate for and provide policy for tribal organizations. And then they have an urban one that covers the urban Native organizations statewide. And they have real good policy continuity. They have meetings on a regular basis. They include tribes in their opioid and addiction engagements. You know, I saw the upsides. I'm sure there's, you know, another box of complaints and places where it doesn't work. But, you know, the other thing that that state system managed to do, even before the Fed started doing 638 contracting in the mid-70s, they already helped put tribal consortiums together so that you didn't have little tribes providing healthcare. And they were there so early. I'm fairly certain they were, you know, before the Snyder Act in 1921, where the federal government was providing health care to tribal people through the Nelson Act and through the Bureau of Education. I studied in Alaska in 1905. You'd have school teachers there, and then the Bureau of Education would actually send out nurses or doctors or people who had some dentistry experience to provide, you know, public, you know, emergency health care, inoculation sometimes, but a whole lot of hygiene and teaching natives how to keep their homes clean and stuff like that. And the Snyder Act, the only thing the Snyder Act did was aggregate all of that and acknowledge that it needed a separate budget, so that you had the BIA being given different budgets. So I'm sure that the Fed was out in California at that time doing that sort of stuff. But in 1958, before IHS got going very far, when you go to California, you find out IHS only has administrative centers, and they've got a couple specialty youth addiction clinics and stuff. But otherwise, it's for the most part fairly large, not large, but bigger consortiums of California tribes, because with few exceptions, California tribes aren't more than 2,000 to 5,000 people. There are some that are just in the hundreds or the teens. So they're relatively small. So they've got consortiums that run specialty hospitals and clinics, and they coordinate, from what I've seen so far, fairly well with the state. I mean, they still have all the healthcare issues. They got revenue recovery issues. They got all the same things everybody else, but administratively, they're, from what I could see, a little bit more organized and coordinated with the state.
Anybody else? Because I would say, you know, to some extent, like Bart is noting, that and Dawn brought up a couple of states, Oregon, Washington. You know, from my perspective, is there's interesting work and innovative, good work being done in a wide variety of states. It's just sort of dependent on where each state has chosen to begin its efforts to kind of engage in some sort of Medicaid health equity incentives or payment reforms, and you know, so it's been going on for some time. I look at, so Dawn mentioned Oregon. Oregon is interesting because they started moving towards a delivery system for Medicaid reforms that's based on care coordination organizations. And so in there you see these CCOs. That's where you see tribes trying to move into this primary care case management, you know, and, you know, when we talk about Indian managed care entities. So you have tribes in Oregon, you know, taking advantage of that delivery system reform and the structure that's there. and the state really partnering and working well and having open communications, and they have really good relationships that they've developed. It seems there's always room to improve on things, but I think that speaks to the strength of what's going on as you have open dialogue and communication with tribal partners or organizations and state agencies. Washington, they have managed care organizations as well as have accountable communities of health. And that was a different approach. Again, trying to improve its Medicaid program and operations, but trying to work with maintaining some health equity and healthcare oversight and social service sectors to a geographic region, but yet allowing these managed care entities to come in. And it was sort of like, and this balancing act. They each have sort of different authorities and different sort of roles to play there. So they're trying to find another way. But again, they're working with the tribes. The tribes, for various reasons, have now established good relations. And there's things that can foster that. Sometimes it's lawsuits, but I look at states like Wisconsin. I think Wisconsin has a really great home and community-based service system, but they took a different approach in establishing their Medicaid waivers. And there was some time ago, the feds allowed for combined waivers, and these Medicaid waivers. You can have a Medicaid, 1915I or Medicaid 1915J or a K waiver, and they're all different specific target groups. Could be elders or the physically disabled or people, with intellectual disabilities. And so you have these different target groups. But Wisconsin, I think, did a good thing over the years is they combined everything and all these different target groups into one waiver systems. It's got a very robust home and community-based long-term care service system, even though it's in a managed care environment. It's very robust in the services. And they also have a self-directed model, where you can self-direct your services and your care provider. So there's interesting, examples of I think where different states are doing good work to bring about greater health equity, and they're doing it in a way that's trying to be inclusive and really recognizing they need to work with tribes. Sometimes it's because there's been a lot of, resistance, but eventually people work through that and find they have to work together for the greater good. So I would say, and then there's other states we could go into in different examples, but it's pockets, of unique information, unique incentives, or I should say, reforms, and some work better than others. And again, we just try to find what works best and carry that message forward.
Remember that tribal and Indian health service facilities and programs exist in only 32 states. There are 18 states where there are no tribal or IHS programs. I'm not even sure if they count DC, because IHS obviously is in DC, but and that's complicated by the fact that the IHS program is one of the few nationwide programs besides veterans, Medicaid, Medicare, and most recently the Affordable Care Act. Otherwise, we don't really have a national healthcare system other than as a safety net. We don't have an affirmative healthcare system. There are some places like Hawaii and Oregon and Massachusetts who are trying to create that at the state level. But the other places, are pushing back, trying to stay away from it. Oklahoma, where you have lots and lots of natives, basically is a red state and doesn't want Medicaid plus, enhanced Medicaid, or anything else to do with the federal government. So, that list has all kinds of profiles.
No, thank you for all of that. I'm thinking about Crystal's initial question, and you guys gave us so much insight, but I don't think there's, like Dawn said, a fix it to how we can really push these programs and kind of work in these policies. And so in my head, I'm thinking like, it's easy. Like, let's just all the states do the same thing. Let's everybody get on board. But and I might be wrong for this. Maybe it's the romanticization in my head or whatnot. I think everything just starts with the intention to truly serve and understand Indian country, the cultures of Indian country, and the needs that these communities have. And when the states really kind of say, we actually have to pay attention to what they're asking of us. And maybe all of these long and tried processes don't actually work for them. We need to modify them. I have a naivete to me in a sense, but I feel like it all comes from that first initial like intention of we need to do better by them, and then everything falls into place. And like Bart said, no, they don't need to necessarily kind of like scratch everything off the table and start from zero, but it's being open to the tweaks and the modifications to meet the needs of this super special and specific population that has been underserved for so long. So no, thank you for sharing all of that with me. I'm like over here, like, I know you guys see me like just nodding away, but I'm just taking all these mental notes all the way. It's such an interesting topic for sure. But with that being said, we're talking about the role of the state and whatnot. What are some state level policies that Indigenous Pact pays attention to and kind of tracks?
Well, I think really for us, the biggest one is we are focusing on those tribal FQHC states. It signals a lot, to me that there's, it provides a signal that there's other opportunities than within that state likely to bring about some additional reforms or to make some improvements. So that's kind of one area. The other area I think I'm really scanning a lot of and serving is around telehealth. And the telehealth rules and regs and provisions, because this again is an area that states have a lot of authority right now as to regulating what type of telehealth services, what type of delivery modality is going to be allowed. And I love that. It would be nice if like, hey, the feds would say, no, all things, all times, always, but no, since it's just this shared program, states really have a lot of oversight in there. So I'm watching and trying to keep track of that because it's a lot of these we've seen. So for example, we've seen a massive expansion in the use of telehealth services since this pandemic hit. And it's proven that it's not going away, that as a general population, that it's provided a great deal of access and met a need for a lot of people, and not just because of of health related reasons of COVID, and distancing. It's just helped stay connected. One of the things I find that I'm really focusing in on is the audio only reimbursement component for telehealth services. Right now, there's 22 Medicaid programs that reimburse for audio only telehealth. And it's important, I find, especially when we're dealing with Indian country, because we know we've the broadband, the connectivity issues. I mean, it's a challenge, but most everybody has a telephone, whether it's a landline, or a cell phone. I got my mom, she's got a cell phone, still learning to use it. Great, but she does. She's learned how to text. She's not learning how to do video. It's like, but it's taken a while, right? But we always got a landline. So, I mean, just having a means to connect to a medical professional through just a telephone, that's one of those areas I think every state should adapt. But now we only have 22 Medicaid programs that are reimbursing it. That's jumped from like a year ago. There was only 15, and so now there's still pushback there. But I mean, that's one of those things I look at as far as a state sort of a policy and practice that I'm trying to pay attention to, that I'd like to really encourage states to adopt, all of these different modalities. The other part of it is, we talked about the shortage of providers. So I've been looking at sort of, again, interstate licensures and compacts. So, they're limited in the types, maybe some to audio and speech language pathology or psychiatrists, but our nurse licensure compacts, that's one area. Like there's 37 states that have nurse licensure compacts. Well, we've got more states than that. Physical therapy compacts, there's 33 states. The psychs, we know there's a lack of clinical psychologists, but we only have 26 states plus DC that have any type of interjurisdictional compact agreements. And if we overlay that with the telehealth component, it's really critical to meet the shortage of providers and specialties and care in so much of our country, that we need to be able to start bridging these connections to people and experts and medical professionals, to people in their home, to other clinical and clinicians. And like, we need telehealth. So to me, that's one of these areas that I'm kind of looking at state policy and what things we might be able to influence as we're able to engage and build out our systems of care. Like, what's that telehealth component? How does that fit with our mobile medical units and other our narcotic treatment programs, et cetera? Much less to meet the needs of provider shortages, or certain specialty access areas.
there are cross-state border issues, as Ashley pointed out, just in licensing professionals and authorizing services. One of the other areas that we are focusing on is managed care organizations. The tribes are already part of it because the states are the ones that license the MCOs and oversee the managed care organization programs with federal standards. You know, there's federal law that sets out standards, but the states are the ones that implement them and have their own rules. And the crazy thing is that there's literally dozens of managed care providers at various levels that specialize in different types of services, but there's maybe a handful, 5 or 6 big ones that go national. You know, there's maybe 2 or 3 that are the biggest that cover the vast majority of the states. So they're kind of national already, but they have their own game that they have to play to, you know, check the boxes on the rules of each state. But tribes, yeah, maybe, I don't know, maybe 80 or 90% of the tribes happen to be within the boundaries of a state. But in most cases, tribes don't give a damn where the state boundaries are. It had nothing to do with them. Certainly Navajo thinks that way, since a third of their population's in New Mexico, about 2/3 is in Arizona, and then there's a few more up in Utah and Colorado. And yet, when we go in there with an MCO, we had to organize it in New Mexico. And there's an imaginary line between New Mexico and Window Rock, their capital, where Arizona starts. What does that matter to Navajo? Doesn't matter a damn bit. But we have to work by the rules of New Mexico to set up this MCO where we're getting pushed back because of some political chess that's being played there. So, you know, the state boundaries create artificial barriers, really artificial barriers that have nothing to do with tribes. And it's in healthcare, it's in all kinds of areas. And you know, you're saying try to get the states to get along with tribes, try to get states to get along with states, much less the Fed. You know, I mean, they're fighting over water rights, they're fighting over this, they're fighting over that. And now there's all kinds of new fights that they brought up, you know, and there's a whole new list nowadays. So, you know, in the meanwhile, we're simply trying to keep people healthy and improve their access and increase resources. So, yeah, I'm kind of surprised that we don't employ more gamers, because that's kind of like what we need.
Well, you're onto something there, Bart. I didn't it's a new idea. Well, as you were talking, the last thing I wanted to say then is the other area is on this COVID really highlighted it, and it comes to our public health authorities and states recognizing the tribal public health authority, and just watching how that continues to play out, and where these jurisdictional boundaries have been established. And so again, it's somewhat of a game of scarcity, it seems. You know, we have these public health districts, and so tribes have traditionally been left out of that, you know, the funding and how states coordinate and their county coordinators. And it's just, so that's just kind of a general other area that I'm
Yeah.
starting to keep more of an eye on. But go ahead.
It's not that they've been left out.
Okay.
They form these public health things and say, hey, you know, all of these things that this New Jersey lady living in Albuquerque needs is perfect for the old grandma way the hell out in the middle of nowhere on Navajo. And that's where tribal managed care organizations benefit, because managed care organizations, at least tribes, have the obligation to provide specialty services as part of their obligations under the management contract for an MCO. I think that the major MCOs also have something similar, which is why they offer, besides just reimbursement, they also offer a portfolio of services that go above and beyond the Medicaid requirements. And with tribal MCOs, they're able to tailor those to tribal needs and, you know, tribal member needs. And that's where it kind of intersects with what Ashley is talking about in public health. In most cases in a state, the public health concerns are determined by the largest population centers, or what the people in the capital think are important, or the lobbyists who are talking to them. And there are not that many tribal lobbyists in there pushing tribal health initiatives, although there may be a few more now with the 638s. but most of them are so busy just getting work done from 8 to 5 that they don't have time to travel to Santa Fe or, wherever to try to impose themselves on state policy.
And doesn't that just kind of like drive you crazy? That grinds my gears. I know, and you can't. I guess sometimes you can't help it just because you get it. They have their job. They're doing. They're trying to play their role or their part. But I always find it. Anytime I get any questions with the work that we do alone and not related to healthcare, there are so many misconceptions. There's so many things that people think that just aren't true, or have no relation to tribes, or no, that doesn't actually benefit them and whatnot. So that's why I love these podcasts, because it helps, like Dawn was saying, like it's the start of providing the information out there to really educate and inform individuals to see where we can help, or just inform our tribes. But with that, let's go ahead and jump on to the next one. So how can state policies be leveraged or changed to create more health equity within Indian country? I know we kind of dabbled in this just a little bit, but you can all expand.
I'd like Ashley to expand on this, but we've talked about tribal FQHC. What we didn't say was where it came from. This initiative just didn't, start popping out of the ground and growing flowers. It was an initiative by CMS. And it was an effort to try to get the tribes to take up this policy over a limited period of time. And they've had to extend that deadline a number of times now. Their intent is to get tribal FQHC to every one of those 32 states. And for example, we're working in New York right now, and they don't have it. So Ashley, why don't you talk about the consequence of only 14, even if they are inconsistent, only having tribal FQHC with respect to health equity, and this notion that it has to be pushed to all 32.
Yeah, and one of the things I found interesting is even though the CMS has sent out, state health official letters talking about these services received through tribal facilities and the need and the opportunity to kind of correct that through this mechanism of this tribal FQHC designation, I'm finding that maybe not all state health officials read those letters. I'm not sure. It gets lost perhaps in this channel of communication, because that deadline, I mean, this has been going on since I think 2016, 2015 is when the first letter came out, and then it continued to get extended. And then, CMS would hear back from states like they were making no progress, or, it's just this delays, and then it was going to be October of 2021. And then it got pushed to the end of, as we're getting up to October, like, geez, there were 12 or 14 states. So that's leaving out a lot. So CMS is like, well, let's extend it to the end of the year. Well, I'm pretty sure now that's, of December 31st of this year. Well, I believe it's now pushed out to the end of January of next year. I have to verify that. But there's been this sort of soft deadline that CMS has had saying, hey, states, because it doesn't really take anything administratively, from what I understand and what I see, for states to really designate a tribal, program. If it's a tribe or multiple tribes that want to obtain that tribal FQHC designation, it's really just a box in their Medicaid information system. Tribes don't have to go through any more evidence or proof. They're already considered, federally qualified health centers by the fact that they're a 638 facility, run by a tribe. I mean, so technically from the federal level, they are federally qualified health centers, but it's really just the state has to check a box, and then figure out how to, do all the rest of this, payments and all. There's a lot of more work to it, but it's surprising to see that there's just all the states don't have these policies in place. That it seems like this memo is lost in the shuffle. And it starts to speak to me like, well, maybe that just says the state of affairs between state and tribal relations, and some of the other state-federal relations there. It just sort of kind of shows, in my mind, in my opinion, like that's my interpretation. It kind of gives us a flavor of what's going on there, which again, I think is why we're focusing on those that seem to be more open to the concept, because there's benefits, and that's a part of it. It's this shared it's a savings on the state's Medicaid budget. You know, they might not call it a savings, but it's a savings. I mean, the state share isn't going to pay for the health care of these Indian folks and not in Alaska Natives. It's the federal government's dime, you know, and so all our money collectively. But, you know, it's just there's a greater, you know, tribes are often the greatest employer in their counties and in their area, the largest employer. Well, if you're expanding healthcare operations, that's economic generation, that's jobs, that improves the well-being of everyone. These tribal health centers, I think, in these regions, in the more rural parts of the state, they're able to, I just see them as being a very underutilized partner and a potential resource to really help augment the healthcare needs of all citizens in the state, you know, of all people in the region. And most tribes, if they're able to take care of their people, they're willing to take care of others if they have the capacity and they're going to get reimbursed for it. You know, a lot of, you know, the health directors and folks are like, fine, you know, like we can run this as a business, but it just takes some time. But it always starts as like our citizens and our people need to be cared for first. So that's always the focus. I get it. But there's room in my mind and what I can see, and there's examples of it where tribes are great partners and to work with, and they have, if we can expand what they're able to do in the healthcare sphere, it's going to meet the needs of entire regions. I just see it not being, I don't know, there's a lot more to it perhaps, and maybe it's just all in my head, but I can sort of see this potential, you know, like, and that's sort of what drives a lot of my intent is like, okay, there's resource, there's human potential, there's needs, and and tribes are willing to do their part. I know Native folks, man, we're some of the most generous people and have the most generous hearts and spirits of anybody I've ever met, you know, and that's not going away. And I think, you know, some of these messages just get all lost. And I just think, you know, it's for a shame. Like Cora, you were kind of mentioning, it just seems like it should just be so easy. Why don't we just all get along? Kind of, you know, you know, but go ahead, Bart.
I think this is one thing that the states and the tribes share. And that is that, you know, if you look at a 638, they've got this very big, complex contract to provide healthcare services. And they're just slogging every day to provide that, to try to, you know, take care of that budget. And so when somebody comes in and says, hey, I've got an innovative idea, they roll their eyes, turn their head, and go back to their desk. Because they say, oh, shoot, what that means to me, because they're good bureaucrats, is more work. And they say, so my boss is going to give me, you know, the 21st thing for me to do, not just the 20 on my list. And so they go, oh, no. And that's one reaction. The other reaction is, hey, the IHS tells me what to do, not you. And, you know, we do it this way, always have done it this way. And, you know, go talk to my boss. And you get the same message from the state. You know, hey, I'm a bureaucrat. I got too damn much to do. You're telling me I got to get something, and you're promising me money. Yeah, I see that on my computer every day. Somebody promising me money for doing nothing. And so they have that, and then they have the same reaction. Go talk to my boss. We have our rules. I have my rules. I'm in the middle here, down low. I don't have that authority. So we have to run through these authority structures in order to try to find action. There's only a very small percentage, but there are some that then go to the very top level and sort of philosophically say, we don't care if we get more money. We're against spending federal money, you know, because this is our money. You know, the hard red folks who don't want to see enhanced Medicare, Medicaid, or anything like that. And it rolls over to us in tribal health. But I think that's a smaller number. And then there's simply another number that simply says, hey, I don't know, it's too complicated for me. And, you know, go talk to somebody else. So we get all kinds of pushbacks. And it's only, you know, the 1 out of 10 that says, oh, I'm inspired. I came here to work, to grow. And you talk to a bureaucrat and you find them like that, it's like, you know, finding that big diamond in the rough. Because a lot of them have that inspiration, but very few of them act on it.
Thank you for that. Oh man, this conversation, I've been so like, tell me more, tell me more. So this has been great. Does anyone else have anything they want to add, you know, really quick about the last question or anything else for that matter?
Yeah,
Well,
I
I
just want to throw.
opinion.
Oh, go ahead, Dawn. Sorry.
I have my opinion with some of these state. I mean, it's political. You know, you have tribes that are running a very lucrative gaming operations and it's a huge impact in the region. You know, why should they get more money? You know, they're already not paying taxes, you know, and it's all that misconception of, you know, oh, tribes don't have to pay taxes. They're living for free. So, and again, this is just my opinion. So you have somebody working at the state, at the Indian Help Desk, which is in the corner closet at the state building, and they're not sure how to, you know, execute on some of these, you know, regulatory or policies that are being passed down. But also, their neighbor is, you know, American Indian or Alaska Native. And they just feel that, you know, they're getting all these advantages, you know, they may work at the casino or they work at the tribal health center. They're getting free health care. They're getting free prescriptions, you know, so I really, my own opinion, feel that that adds, you know, to this mindset of motivation. Do I want to help? Is this going to, you know, help all of the citizens within this state? Nope, it's just helping that Indian tribe that's running that casino. So again, that's just my opinion.
Yeah, what I was gonna say, I was gonna go off what Bart was saying, how bureaucrats often, you know, they don't want to take on more work than what they already have going on. There's, you know, a ton of work to be done day in and day out. So that you just sort of end up pivoting around from office to office. You know, you get sent, oh, maybe they'll answer your question, or go down the street and maybe they'll know, and you never actually get anywhere. So when we were talking about success stories from other states, what popped in my mind now was Washington State. Their state legislator passed a bill that directed their healthcare authority to collaborate with key stakeholders, including FQHCs, rural health clinics, MCOs, and they all had to get together to produce recommendations for a new payment methodology that would reward innovation and better health outcomes over volume of services delivered. So when we talk about states that have met a lot of success, you know, implemented TFQHC policies and things like that, oftentimes I think it does come from just trying to get everybody in the room. That's half the job, just making everybody, you know, want to work together, get on the same page, because obviously nobody wants, you know, worse health outcomes or less money being sent to clinics that need it. But I do think that that is half the battle. And somewhere like Washington, where you can, you know, pull some of the research together and say, this worked, the state told everybody to get in the same room and talk about it amongst themselves and, you know, talk about what they need to make it really happen. I think that's a great model for, you know, other states to follow and for us to try to help other states accomplish an Indigenous Pact. So I just think that that's a really important aspect of the whole issue.
No, I agree 100%. Cora and I think one of the reasons why we get along so well, I think, is because we're both very like kumbaya. Let's just help everyone. Let's get everyone on the same page. Let's see what we can do to assist in any way possible. And it's nice to, you know, to be among, you know, like-minded people who are willing and wanting to do that, you know, for the greater good, you know, that kind of thing. And Ashley, like you were saying, yeah, I agree. I've been to other tribal reservations and whatnot, and natives are definitely one of the most giving people, if not the most giving people and welcoming people I've ever come across as well. So it's like, let's work together. Let's just make this work. So yeah.
You know,
Cora,
just
go ahead.
one last thing. You know, we talked about larger visions, and in some respect, you know, the ACA is the closest thing we've had to a national healthcare policy. Otherwise, even the Republicans are saying, yeah, we don't disagree with it, but why don't we experiment at the state level before we do anything at the federal level? If you look at it that way, IHS and tribal healthcare programs are a large experiment about how to deliver healthcare moderately uniformly across the country with one group of people. Some states are trying to do that in their own states, like Massachusetts, like Oregon with their quasi-private system. And Kaiser Permanente in Hawaii has been doing it a long time, providing a statewide program. So, you know, at some point, the tribal program that we are, you know, arm wrestling and leg wrestling and try to make it more effective and more open and bigger, and more accessible is one that may be the training ground for a national healthcare system. It's kind of spooky to think about that, given what we know about the current system. But I think we're facing all the same problems that a national one would face in meeting up with states and trying to break down state barriers to a national program. So if you think about it in that way, we're doing more than just our job, I think.
No, I agree with you, Bart. And to Dawn's point, I really do think that there's such a lack of education about what Native communities experience and the needs of Native communities, and so many misconceptions that also hinders the growth of programs like this. And I, as a teacher, I spent some time teaching in a reservation, and a lot of the misconceptions that Dawn mentioned, I've experienced firsthand, where I was like, well, why do they even need a school? They already have all of it. And it's like, no, but they need, like, these are grossly underserved communities that need so many of these services beyond just healthcare, right? And health equity. So I'm with you guys 100%. So I think we need to continue to have these conversations, continue to use our platform to further educate the public, and just kind of put the issues out there for people to kind of wake up and say, we need to do better. So that brings us to the end of today's episode. Thank you again, Ashley, Dawn, Julie, and Bart, for joining us for a second round of conversation here. I truly enjoyed today's topic. And as always, thank you to our listeners for jumping into the Hobothania podcast. If you enjoy our show, please make sure to like us and rate us on Apple Podcasts, Spotify, Google Podcasts, Simplecast. And please visit our website, www.nativelearningcenter.com, to find information on upcoming webinars, virtual trainings, and future episodes of our Hobothania podcast. So thank you, everybody.